Good evening, one and all. On behalf of CSI, Cornea Society of India, I welcome you all to this Kera Grand Round Season 2. This event was conceptualized last year, and we ran about 4 meetings last year, and that had received very good response. And based on that, we thought that we would continue the same this year as well. So for today, generally we try to take very common conditions for which we don't have many answers. And today for that we have wonderful subject, that is, we would be talking about all you wanted to know about AdenoViral KeratoConjunctivitis. For this, we are very fortunate to have a wonderful panel with us. For this, like, we have stalwarts from one of our Apex Institute from India, PGI Chandigarh, Professor Arun Jain, who is professor and head of the Unit 2 at PGI Chandigarh, and he is a cornea, cataract and refractive surgery consultant. Everybody knows him so very well. We have Professor Amit Gupta, who is part of the same institute, and Professor Chintan Malhotra from the same institute. We have other two panelists, Dr. Srinivas K. Rao, who is very well known as a wonderful teacher, and he's from Chennai. Dr. Merle, who is a very dynamic director at LVPI Hyderabad. And she also runs a lot of other things, like she's a network director for finance and accounts. And our all CSI executive committee members as panelists. Next, please. We have wonderful cases by various presenters who would be introduced by my co-moderator, Dr. Anchal Gupta. Dr. Anchal is, an assistant professor at PGI Chandigarh, and she has done a lot of research on AdenoViral KeratoConjunctivitis, and she was really wonderful. She is a really wonderful person to take care of this subject. She literally did the background work for this. So without, losing much time, we would just move on to the main session, and I would like Anchal to take over this session for, starting the case discussions.
Thank you, ma'am. Thank you for giving me this wonderful opportunity. So straight away going to adenoviral conjunctivitis. We all know that it comprises about 65 to 90% of all viral conjunctivitis. And there are actually no standard management protocols on how to treat. So just few slides on the typical presentation of adenoviral conjunctivitis. We know it ranges from mild lid edema to very severe chemosis, as well as very thick pseudomembranes. So just move the next slide. Yeah, so this is a short clip of a pseudomembrane peeling. These are all the very typical typical presentations of adenoviral conjunctivitis. So for today's session, we have a mixed bag of very interesting presentations, including some masquerades. So we'll go ahead with the first case, which is by Dr. Pranita. She is a consultant in Center for Sight, Hyderabad, and we'll play her presentation about demystifying red eye.
Good evening, everyone. I'm Dr. Pranita Sahai, working as a cornea consultant at Center for Sight Eye Hospital, New Delhi, and I'll be presenting a case of acute red eye that was managed in my OPD. So this was a 47-year-old male who presented with complaints of redness and watering in the right eye since last 20 days and reported worsening of symptoms with the ongoing therapy. The primary treating physician has diagnosed him as a case of acute conjunctivitis and treated with FMLT eye drops 3 times a day with lubricants for 1 week. However, in view of persisting redness, he shifted him to Vigadexa eye drops 8 times a day in tapering doses. On examination, the visual acuity in the right eye was 612 and the left eye was 66. IOP was normal for both eyes. The right eye showed diffuse conjunctival congestion with presence of follicles, a clear cornea, no anterior chamber reaction, the fundus being normal and the corneal sensations also being normal. A closer look at the conjunctiva revealed necrotic patches in the inferior conjunctiva as well as the temporal area. The superior limbus was not also giving a very healthy look. On ocular surface staining, all these areas of necrotic patches were taking up fluorescent staining, which was showing a geographic pattern for the conjunctival ulcers. The superior limbus showed fine evolving dendrites on rose Bengal staining. Hence, we made a diagnosis of viral keratoconjunctivitis with geographic conjunctival and dendritic corneal ulcer. The patient was started on topical antiviral therapy along with antibiotic, lubricants, and cycloplegic drops, to which the patient responded well. These are the pictures of day 3 follow-up, where we can see the congestion had dramatically reduced and all the areas of conjunctival ulcers as well as the corneal ulcer had resolved. Hence, to summarize, this was a case of herpetic viral keratoconjunctivitis, misdiagnosed as adenoviral conjunctivitis, treated with steroids, which resolved well on starting antiviral therapy. These are the images of 1 month follow-up. The eye was absolutely normal. Hence, not every case of acute viral conjunctivitis is adenoviral. A cautious use of steroids in conjunctivitis is a must, with the indications being limited to pseudomembranes and subepithelial infiltrates, resulting in diminution of vision. Ocular surface staining can highlight subtle findings, and herpetic infections can also present with geographic conjunctival ulcers. Thank you.
Yeah, we'll move on to the second presentation and then we'll have the comments from the panelists as well as some questions for the presenters.
An 82-year-old lady presented with a 3-day history of swelling, redness, and watering in her right eye. On examination, there was lid edema, conjunctival hyperemia, few follicles in her lower palpebral conjunctiva with membrane deposition. Her cornea was unremarkable. So based on this presentation, that is acute, unilateral, follicular, membranous conjunctivitis, a clinical diagnosis of adenoviral conjunctivitis was made. So we peeled off the membranous deposit, sent conjunctival scrapes for viral PCR, and started her on topical povidone iodine 1% QID and moxifloxacin dexamethasone combo 6 times per day. However, 4 days later, she came to us with this picture. She had multiple scars along the distribution of ophthalmic division of her right trigeminal nerve. Lid edema was still present. Conjunctiva was still hyperemic with follicular reaction. There was no pseudomembrane, no hemorrhage. Cornea had punctate epithelial keratitis, no pseudodendrites, no infiltrates. Anterior chamber was quiet. Her PCR was also positive for herpes zoster virus. Now, our diagnosis was conjunctivitis due to herpes zoster virus. We started her on oral acyclovir 800 milligrams 5 times per day for 10 days. Oral acyclovir shortens the duration of illness by accelerating cutaneous healing and decreasing new lesion formation, also decreasing the severity of acute pain. 10 days later, there was marked improvement in her signs and symptoms. Thus, conjunctivitis due to herpes zoster virus can masquerade as adenoviral conjunctivitis. The conjunctival changes seen in herpes zoster ophthalmicus can include papillary or follicular reaction, chronic hyperemia, and even pseudomembrane formation. Vesicular eruption may occur within the conjunctiva with possible hemorrhagic changes. With severe conjunctival changes, extensive conjunctival scarring and symblepharon formation may ensue.
This was a presentation by Dr. Shraddha. She's the MCH working in Advanced Eye Center, PGI. I would like to invite Dr. Rao for his comments on the first case, please.
Thank you. Basically, I'm not convinced that's a herpetic keratoconjunctivitis. Basically, I've seen this happen with FMLT. For some reason, even though it's made by a multinational company, the FMLT formulation is quite toxic to the surface. The FML is not. None of the features that were presented preclude a diagnosis of medicamentosa. All the inferior conjunctival ulcers are typical in a medicamentosa, that kind of an ischemic necrosis that you get because most people put their drops inferiorly. The herpetic dendritic ulcer is not very convincing. When you have epithelial toxicity, one of those pictures, I don't know if you saw supratemporally, there was a dry skin-like appearance on the cornea, which is typically seen in these allergic cases. And there, when the epithelium breaks down, sometimes it can mimic a linear lesion that may suggest a dendrite. Because if you've had somebody who's a herpetic patient without antivirals on a steroid for 20 days, I would expect a geographic amoeboid ulcer and not a typical dendritic ulcer 20 days later. So to me, that looks more like a drug toxicity from the FMLT. Stopping it and switching it to some other steroid and tear substitutes can also help resolve the condition. One way you can maybe judge if this is the case is asking the patient if there was a lot of stinging when they were putting the FMLT in. Usually the drug that's hurting the eye will cause a lot of toxicity, and they're quite specific. Even though they're using 4 drugs, they'll tell you that only one drug really hurts them when they put it in the eye. So I'd like to hear the others, but to me, I don't think that was a herpetic keratoconjunctivitis.
Dr. Amit, would you like to comment on this?
Yeah, I think I tend to agree. Having that kind of a conjunctival ulceration we have seen, especially with tobramycin, and particularly with the tobrazone and FMLT drops, and but that would classically, it would be much more intense inferiorly. What we saw here was a very kind of diffuse kind of 360-degree conjunctival congestion, as well as that really a boggy looking conjunctiva which was there, and we are really not sure what is what. I'm afraid I can't agree with the diagnosis of herpetic as well. It was not a classical dendritic ulcer, and I totally agree with Dr. Rao. He's given such a wonderful insight into this case that after a steroid exposure we would expect a much larger and a much more classical ulcer.
Thank you, sir. Coming back to acute adenoviral, sir, your views on role of ganciclovir in acute adenoviral, because we need to discuss that. If we consider it as acute adenoviral conjunctivitis, what are your views on role of topical ganciclovir?
Maybe we can ask Merle. I think she has something to add before we go on to that question. Maybe I think she has something to add about the diagnosis. Merle?
Yeah, so I want to play devil's advocate here. Okay, so you may have, if we're going to say that it's keratitis medicamentosa, so how do we explain the absence of SPKs on the inferior cornea? And how do we explain the presence of this lesion in the superior cornea, which has some cellularity in the stroma, which one would not expect to find in a patient with medicamentosa unless they've had a long-standing, I mean, I wouldn't expect to find something on top. So how does one explain the 12 o'clock lesion, which was on the cornea, and the fact that you have these patchy lesions kind of, all around?
The finding was not presented, but something that I find very useful in these patients is to look at the inferior tear meniscus. Often because you're watering and all that, you'll have a very elevated tear meniscus. And if you see a lot of granularity in the tear meniscus, that's a sign of a toxic conjunctivitis as far as in my experience. And in these patients, we have seen that dry skein-like deposits on the superior cornea. I don't know if you can play those slides back again, whether you have that facility, but I did pick it up in one of those, one of the corneal pictures she showed, just temporal or to the left of the staining area, you could see that dry skein-like patch. I have seen this in toxic keratoconjunctivitis. They get that deposit. I don't really know what it is. I've never scraped it off and looked at it histopathologically. But here the steroids will help. And FMLT, even though it's a steroid, for some reason, that particular formulation, and I've spoken to Allergan about it as well. I've seen multiple patients present with problems with that particular formulation. I don't know what it is.
Just to interrupt, sir, I would just like to add on. The patient at that time was on Vigadex 6 to 8 times a day for the last 1 week. So when he presented, he was not actually an FMLT, but was on Vigadexa. And drug toxicity definitely was one thing that was also in my mind, because the patient was on extensive steroid dexamethasone drops as well. And with steroid use also, conjunctival ulcers have been reported. So that was obviously in my mind, but acyclovir itself is a toxic drug. So considering that we are taking this as a drug toxicity, with the addition of acyclovir ointment, things would have worsened. So I kept the patient on a close observation, considering that if it's a drug-induced drug medicamentosa, so it's going to worsen, and then I will stop the antiviral, shift him back to only lubricant, and stop the steroids as well. But surprisingly, within 48 hours, all the ulcers healed, despite the fact that the patient was already on the same lubricant which he was with Vigadexa, The only thing which was changed was stopping of Vigadexa and adding up of the topical antiviral. So that is one thing which,
like Merle said, I think just trying to offer an alternative explanation. It's at about 10 o'clock there. That reflects that you see in the cornea, just inside the limbus. It's even better seen in one of the other slides. That is the area that
47-year-old male who presented with complaints of redness and watering in the right eye since last 20 days and reported the primary case of.
But like Merle said, I mean, if you don't do herpetic cultures, it's very hard to say which of us is right. But anyway, the treatment would be similar except for the acyclovir that was added here. That 10 o'clock area is what I was trying to point out.
Stop
just
here.
inside the limbus, somewhere there. So,
Shabina.
yeah, particularly if he was bigger DEXA, then again, my point would be that the herpetic dendrite would have flared up even more compared to FML. If you've been treating them with DEXA without covering antivirals, I wouldn't expect a small, thin 2-3 millimeter linear streak. I would expect a very large geographic amoeboid ulcer. But then, yeah.
I have a question. How common is it for, topical drop-induced toxicity to be involving the whole of the eye? I mean, it's very rare, I think.
So I think, okay, go ahead.
No, go ahead, Dr. Jain.
Yeah, because as Amit is saying, because we have seen also many cases of FMLT-induced reaction, but more so they are limited to the inferior fornix and inferior half of conjunctiva. So to having a diffuse reaction and a chemosis of conjunctiva, of course, chemosis will be there if there's the acute drug reaction. And we have also reported, we have seen 2 cases like this, and we have already reported this in literature maybe around 10-12 years back, who were not on any treatment, and they presented with multiple conjunctival ulcers, and they also had multiple corneal dendrites. They were not on any drug. So I don't remember the name of the journal now. We can fish it out. So it can present, but of course, the differential diagnosis could be anything. Yeah.
It could be an adenoviral conjunctivitis on which the toxicity was superimposed, which can explain the general diffuse conjunctival congestion with the additional findings inferiorly. I'm just saying that I didn't think to me, it didn't look like a herpetic keratoconjunctivitis, but it does not rule out an adenoviral keratoconjunctivitis on top of which the FML was doing something. I mean,
I would like to pose one question. Have you ever seen any adenoviral keratoconjunctivitis without punctate hemorrhages? I have never seen. Because in this patient, the patient didn't have any single dot of hemorrhage, as far as I could see.
Yeah, so I think there are features everywhere.
Yeah.
For adenovirus, for herpetic, and for toxicity. So maybe a combination.
Yeah, because all these 3 viruses belong to same group, DNA virus of this thing, and there's a large overlap in presentations, but some of the distinguishing features are there. Yeah.
Dr. Pranita, did you ask about the stinging sensation with the FMLT? Is that recorded at all? I'm sure it's hard. Sometimes you don't ask for these things. Maybe it was not.
So the patient was saying that every drop, whether lubricant or the steroid antibiotic, everything was hurting. It was just a generalized pain and discomfort and worsening of symptoms that he was reporting.
And sometimes when you have one medication that triggers this, sometimes it just goes on to an overall toxic state where everything just builds on that, that vicious cycle that comes in with the inflammation, and then everything just keeps adding on. So I think the best thing you did was to stop everything and put her back on some, more rational thing. And this is one instance where I like the moxifloxacin because it's unpreserved. So when you're really uncomfortable without an antibiotic, then here something like a moxifloxacin is probably my drug of choice for an antibiotic effect, if you want one.
Yeah.
I think at the take-home point for me would be that in case one keep drug toxicity in mind, and in that case, what we can do is maybe discontinue topical medications for some period of time. And sometimes these patients have a dramatic improvement before we jump on from one treatment to the other without having a confirmed diagnosis. Anchal, anything else?
Anshul, can we move on to the next questions?
Yeah. So we would like Dr. Paras to reveal the results of the survey, and then we can move.
Actually, what we did was like we had prepared a questionnaire and we had circulated this Google survey amongst the members. And this was designed by Anchal. And what we looked at is, we also looked at the professional status of the people who responded. And it was very interesting to know that almost, 70% of the people were specialists who had an experience of more than 5 years. And rest of the 20%, 30% were, contributed by trainees and specialists. Can we move on to the next slide? Shabina, next. Out of the responders, we received 143 responses within this much time, and out of which 60% were from the institutional background and 40% from the private practitioners and individual practice. We also looked at, the treatment pattern, like we had put few answers for that, like which treatment would you choose in a patient with acute adenoviral conjunctivitis. And we received, maximum people agreed upon using artificial tears. People, almost 83% said they would be using artificial tears. It was good to, heartening to see that 50% of the people responded that they would like to use topical steroids. 17% said that they would like to use additionally topical antivirals also, and 55% people said that they would also like to add topical antibiotics, and almost 16 or 17% people agreed upon using povidone iodine. Based on this, do we have one more slide, Shabina, for this? I think we can, we would like to have an opinion of the panel. What would be their line of management for acute adenoviral keratoconjunctivitis? Whether they would like to use, when would they like to use steroids? When would they like to add, would they like to use ganciclovir or any antivirals? Or would they like to just treat these patients on just lubricants?
I think you can ask by name, Paras, because it's going to get very confusing otherwise. You can, I think maybe we can start with Dr. Srinivas Rao. We always look forward to his keen inputs.
Yes.
Himanshu is here. Hi, Himanshu. And I did see Dr. Nikhil Gokhale also. So I think everybody can quickly, we can give our opinion.
Dr. Rao, your inputs for this?
Basically, for me, if it is not a very severe form, I just stay with topical lubricants. Steroids only if I see very hyperacute kind of a lesion, that tear sign that I spoke about, membranes are forming, or if you see a very brawny conjunctival edema, and then I would add steroids straight away with some antibiotics. Again, like I said, in these situations, I prefer Moxie because it's unpreserved, not for any other reason. I've never used ganciclovir in this. There was only one report when I was reading that showed some questionable efficacy. So I don't use antivirals at all in this condition.
I have a question for you, Dr. Rao. What percentage of your patients would end up developing subepithelial infiltrates without, having any kind of treatment? Could you just offhand have some idea?
There's a current episode going on in Chennai currently, and I think the chance of them developing a subepithelial infiltrate in this particular episode is about 30%. But until this episode, for the last 4 or 5 years, I think it was closer to 70%. Most of them ended up with it. But this particular epidemic, pandemic, whatever endemic thing that we're having currently over the last 3 months now, is pretty strange. They're getting a conjunctivitis, it goes away in 3 to 5 days. Most of them don't get anything in the cornea. So I think it varies by the strain also to some extent, I think. The
Just a
strain that
comment.
causes that episode.
Can be just like a simple follicular conjunctivitis rather than being a epidemic keratoconjunctivitis per se. So it may just
Possible,
vanish
because,
without any corneal.
Correct. None of us are doing any of those tests. Although you have a point of care test for adenovirus, we don't have access to it, so we don't really know. But this present conjunctival, thing that I'm seeing, hardly any subepithelial infiltrates. Until this year, though, 70% ended up with it.
Dr. Merle, your comments on povidone or ganciclovir?
So we were involved in a study that was looking at povidone iodine, along with steroid combination for the management of this. But that was only when the efficacy was found to be when you were 3 days out. So if you use it in an acute setting, because of live virus being present, live active virus being present, it was not as effective. But then after 3 days, the virus is less, it doesn't multiply as much. And therefore, it was more beneficial when given after 3 days. But frankly, even though we participated in that study, it didn't actually translate into clinical practice. So we still give artificial tears. We don't give topical antivirals. And the only time, and steroids, I think, is going to come up. So we'll talk about that later. There's a lot to say about steroids.
Yeah, thank you, ma'am. Should we move on to the next presentation? So the third presentation is by Dr. Divya. She's also doing MCH cornea in Advanced Eye Center, PGI. So we'll go ahead with this presentation.
Good evening, everyone. My topic for today's KERA round. Good evening, everyone. My topic for today's KERA rounds is differentiating subepithelial infiltrates. Does imaging help? These are the 3 cases of AdenoViral keratitis showing different stages of the subepithelial infiltrates which eventually heal and become inactive. During the active phase, we can see the granular appearance of the lesions with patient complaining of the blurring of the vision and photophobia. Coming to the imaging modality, we have done pentacam corneal optical densitometry in these patients, and we observed that during the active phase, because of the subepithelial infiltrate, there is a decrease in the corneal clarity which can be observed in the densitometry values of the cornea. In further due course, when these subepithelial infiltrates have been decreased, the corneal optical clarity has come back, and there will be a decrease in the corneal densitometry values. So by doing this, in some patients we can decide when to start the treatment and stop the treatment. Similarly, confocal microscopy was also done, where we can appreciate the massive inflammation with increase in the number of the Langerhans cells during the active phase with the hyperreflectivity in the anterior stroma. At 6 weeks after presentation, when these subepithelial infiltrates has been start decreasing, we can see that the number of the Langerhans cells were also decreased, and there is the focal changes. When the scar forms, we can see the scar tissue even below the epithelium in the anterior stroma. Coming to the anterior segment optical coherence tomography, during the presentation or the active stage, there are the patchy hyperreflective lesions involving the subepithelial layer, whereas once these infiltrates have been healed and form the scar, there is a disruption of the Bowman's membrane with the hyperreflective plaque-like lesions. So these imaging techniques may help to assess the progression of the subepithelial infiltrates in the long course way, and also when to start the treatment and when to stop the treatment, and which patients to treat, and what will be the sequelae of the subepithelial infiltrates and what we have to do to prevent them. Thank you.
I would like to invite Dr. Chintan for her comments on this case.
Thank you, Anchal. I think usually the diagnosis of, we know that the diagnosis of subepithelial infiltrates, so when they recur, is usually a clinical diagnosis, and we are able to make out whether they are active or not, depending on whether they have fuzzy borders. There's a little bit of subtle edema. The patient reports some worsening of symptoms. But I do think that densitometry is a great tool, especially to follow up these cases. And sometimes when you've not seen the cases earlier, you may have a patient where it's a little gray zone and you don't know whether it's active, it's inactive. You would like to give the patient the benefit of a trial of steroids, but then you won't know where to stop. So in such cases, I think if you start at one point and you have the densitometry values, you give steroids for a little while or whatever you want to give, and then the densitometry decreases, and then it doesn't decrease beyond a certain point. That's where you would know that you can stop your treatment. So I think it's a good tool to have in a follow-up, especially in cases where you are a little bit in doubt whether there's a scarring, there's a subtle edema or not.
Thank you, ma'am. I just agree with you. So, Dr. Merle, any comments on this case per se?
Yeah, I agree with Dr. Chintan because most of the diagnosis is clinical, and we haven't actually found utility in all these investigations, either in the diagnosis or in the follow-up. I mean, you can easily make out when the lesions are active because of that subtle granularity in the anterior stroma or the subepithelial stroma. So you know that it's active. Patient will be symptomatic, and when the lesions are scarred, that granularity is not there. So I think that's adequate clue. As a research tool, yes, definitely. If you want to do research on it and try and document stuff, definitely you can go ahead and do. An ASOCT is good in those areas. I'm not sure about the densitometry, as Dr. Malhotra also pointed out, that you can't actually make out whether it's active or inactive because it's going to show you the same kind of hyperreflectivity that you're seeing. So yeah, because I would err on go towards a clinical management as opposed to using diagnostic tools for this.
Yeah, thank you, ma'am. Ma'am, any role of if we have recurrent SCIs, what will be your choice of immunomodulators like cyclosporin or tacrolimus in that case?
So what I've noticed over time is that when they do develop subepithelial infiltrates, often we do a quick taper of the steroids, and that tends to cause these lesions to recur, subsequently. So what I've learned over time is that if you taper the steroids and if you're giving them a low potent steroid, you taper it very slowly. So either a 2-weekly, sometimes a 3-weekly taper. For the first episode, a 2-weekly taper should be fine, and they usually don't come back with recurrences. But when they do have recurrences, then I usually combine that with either tacrolimus or cyclosporin, whichever the patient can tolerate. They're a little more tolerant of tacrolimus as opposed to cyclosporin. And we taper the steroids extremely slowly. So it'll be like 4 times a day for 2 weeks, and maybe twice a day for 2 weeks, twice a day for 3 weeks, or even 1 month, once a day for another month, and then depending on the response, simultaneously we would start the immunomodulator, and then continue on the immunomodulator for at least 6 months once the steroids are knocked off, and then they usually don't come back with any recurrences after that.
Yes, ma'am. Thank you, ma'am. The slow tapering, I think it is very important, and it's a very important point after this. Can we have the results of the questions of the survey? Then we'll move on to the next presentation.
We looked at this, we asked people that what are their indications of starting topical steroids, whether they would like to start topical steroid for conjunctival chemosis, for pseudomembranes, large epithelial defects, subepithelial infiltrates, or some who would not prefer to use steroids. So approximately 76.2% respondents mentioned that they would like to start the steroids at the time of when they see pseudomembranes. 83% responded that they would like to start steroids when there are subepithelial infiltrates. And even some people agreed upon starting steroids when they see large epithelial defects and even a conjunctival chemosis. And probably by looking at, the previous discussions, we understand that the cases which are having severe presentation, probably to reduce the inflammation, we have to start the steroids and maybe taper them very slowly with an overlap of probably, immunomodulators, so that you can wean off these patients from steroids, and then there would not be any recurrence observed. Do we have one more? Can you move to one more?
Yes, doctor.
Yeah. We also asked a question about, which treatment they would like to recommend in recurrent episodes of subepithelial infiltrates. Like one is steroid, cyclosporin, tacrolimus, or NSAIDs, or they would like to just follow up these patients with treatment. So we can review this question again with few of the panelists. Maybe Dr. Rao would like to comment upon this, and maybe Dr. Himanshu.
I think steroids are yeah, go ahead, Himanshu. Sorry.
Please go ahead. So please go ahead.
No, I was just saying that for me, steroids, I think, are a double-edged weapon in this particular situation. There are cases in which you must absolutely use them, because not just from the point of view of the severity, some of these can go into severe cicatricial scarring of the lobe. I've seen that as well, go into significant dry eye. So in those cases, when you have significant inflammation and membranes, if you withhold the steroids, you're probably not helping them at all. But on the other hand, if you want to use it for every garden variety adenoviral conjunctivitis that comes, I think there is evidence that you may actually increase the incidence of the subepithelial infiltrates, which are an even harder problem to treat. Because I think the subepithelial infiltrates are just a manifestation of the extent of the viral antigen deposition in the basement membrane and in the just above the Bowman's layer. So this can either be from the severity of the infection itself in the first place if the viral quantum is extremely high, or if you interfere with the natural immunity of the ocular surface by adding steroids when they're not really needed, then you may allow a prolonged persistence of the virus in that area, and then the antigens can get shed more as well. So I think while you need to use steroids in some cases, I think there is a case for not using them as part of your primary treatment protocol for adenoviral conjunctivitis as well.
I would just give, maybe I have little different way. I normally in the acute phase possibly never use steroids. As Srinivas said, after the maybe acute phase, when you have, if you have a lot of membrane or something like that, maybe after 5 days or 6 days or, little forward, then maybe I would use homeopathic doses of steroid just as anti-inflammatory maybe. And for infiltrates, subepithelial infiltrates, I never use steroids. And unless the vision is worse than 618, then maybe, or the quality of vision extremely poor, I would possibly try to use cyclosporin and tacrolimus that way. And possibly I'd spend more time in, counseling my patients that the pathology, if you look at the pathology, it's an immune reaction. So unless the antigen is finally destroyed by the immune system, the infiltrate will keep coming back. And I think the adenovirus is different in respect because it doesn't lead to scarring eventually if the antigen is safely removed by the immune process and the infiltrate automatically go away. But on the other hand, like I have patients coming with 3 and 4 years of repeated steroid uses where they tend to have finally scarring, irregular astigmatism, and you need to give a hard lens, otherwise they can't see at all. So I'm very skeptical of using steroids. Maybe in referral practice, we see more complications with people sent finally after, repeatedly using steroids. So I use very cautiously, and I would try and avoid and possibly talk more to the patient too. And most of them will disappear even if you do not give steroid. It's a matter of time and patience. That is what I have observed.
Can I come in here?
Yes, please.
Okay. No, if you are in a hurry, we can later on take the discussion. That's okay.
No, please. We need to have clarity on this because we need to give the right messages to the audience. Please go ahead.
So I guess there won't be any consensus here. There cannot be a consensus here because there's not universally accepted treatment which is out there, and neither you can have a study which is complete with such a huge. The thing is now, COVID has taught us a lot of things about such kind of way handling the virus with steroid, without steroid, and all those things. Interestingly, the literature is there about what Merle was talking about, that we can use betadine along with the steroid, and we had been part of some similar studies, and we found that it wasn't a bad idea earlier when we thought. So I actually follow what Merle said, that if it is first 3 days, possibly I would just wait and see where it falls and whether it becomes a little better off. Then I'm just going to wait and watch, as Dr. Rao said earlier. If it starts with really bad inflammation and post 3 days, the inflammation is really high, I do start them on Vigadixa with point. So Vigadixa comes in 5 ml, and we take 0.5 ml of 5% betadine, like epidine drops, add into that. The idea behind this thing is when we start steroid, the longevity of virus increases. The virus can stay much longer on the surface. Now, in absence of any definite antiviral, if we had any antiviral, like any COVID thing, we would not start the steroid immediately in the beginning, possibly the 7 days, and wherever the maximum inflammation wave comes, and that's the time where we go ahead and there, if we have antiviral, we do prefer to give antiviral. Now, in absence of a definitive antiviral here, betadine, which has a good antiviral activity, we don't mind using that. Having said that, it does have surface toxicity, does sting sometimes. Sometimes patient can be quite intolerant to that. But with the concentration what we use, it's not as bad. Along with the lubricant, it does help you to calm down this thing. So that's in my hand. And whether we have any long-term data, whether using this thing would reduce the subepithelial infiltrate, I really don't think anybody has that. What it shows is you have multiple choices, and you can decide what works for you and how you in your practice can treat that.
Thank you, sir. I think we can move on to the next case and then we can have a discussion later. So the fourth case is by Dr. Amrita. She's a consultant at LVPI Hyderabad, and she'll be presenting on, do they coexist? So we have some other entity along with adenovirus. Let's see.
Hello everyone, I shall be discussing few interesting cases of AdenoViral KeratoConjunctivitis with some unusual sequelae and coexistence. My first case is a 26-year-old young male with history of conjunctivitis in both the eyes 2 months back. Left eye was more symptomatic than the right eye, and he developed progressive photophobia and blurring of vision. On examination, you can see a central ring-like lesion with surrounding SCIs and central stromal edema and scarring, which is evident in the ASOCT. The right eye revealed few peripheral subepithelial infiltrate. Looking at this clinical picture, it is very unusual to be a sequelae of adenovirus. So we tried scraping on the areas of activity or edema, and surprisingly we got microsporial spores, although scanty, on the grounds and the KOH stain. And we also have sent it for PCR, which came out to be positive in RT-PCR for adenovirus, and pan-microsporidia DNA was positive, and it was negative for HSP1. So we started the patient on antibiotic because of the large epithelial defect we created, and for a week, and also topical steroid fluoromethanol 6 times a day. Subsequently, we can see that it resolved very remarkably to the steroid. This is the 1 week picture, but as we tapered the steroid, it had some recurrence of SCI. So we slowly tapered the fluoromethanol over a period of 8 to 12 weeks. And this is the picture at 8 weeks, where you can see some faint nebular to macular scar at the center. This patient had 1 year follow-up with no recurrence of symptoms, fortunately. The other case is again a young female who was treated in one of our secondary center as HSV immune stromal keratitis with oral and topical acyclovir. Here again, it has a similar clinical picture of a ring-like lesion with peripheral SCIs, which is evident in the ASOCT. The edema is evident. And based on our previous experience, we scraped, and again we got microsporidia on smear examination, and it was positive for microsporidia and adenovirus DNA, and negative for HSV1 and other viruses. So we started the patient again on topical steroid, and based on our previous experience with other cases, because of the recurrence, we added tacrolimus in this case as well. This is the 3 weeks visit, where you can see the edema and scarring have reduced. The patient was slowly tapered with topical steroid with a 3 months tacrolimus, and on 8-month follow-up didn't have any major recurrences. So we have published these 20 cases of microsporidia immune stromal keratitis, which had a coexistence with adenovirus in 70% of cases. So here the question arises whether this coexistence or superadded infection caused such a prominent immune mediated reaction, and then it should be differentiated from the HSV so that we don't overload these patients with oral or topical acyclovir. Thank you. This is open to discussion.
Yeah, I would like to have comments from Dr. Jain, please.
Very, very interesting cases, but I think all of your cases had I mean, microsporidia involving the whole of the stroma. There was a huge moderate to severe corneal edema with the ring infiltrate. I have not come across any superinfection. I have seen maybe around 20 odd cases of microsporidiosis, but we never had such severe involvement of cornea, and I have yet to see a case of this superadded infection of adenovirus. In these cases, I can't really comment about this. Maybe some other people can comment about this. I have no experience on this, and I have not gone through this paper. I'd like to go through this paper and have some opinion about it. Yeah, please.
Yeah, Dr. Rao, would you like to comment on this?
No, like Dr. Jain, I don't think I have seen this particular presentation. I think they are basically the focus is on the immune processes in the cornea. That's interesting because the way they treated it and the way it responded certainly does suggest an immune process rather than an actual infective process. Because if it was microsporidia sitting in the stroma, generally it continues to worsen until you operate. And I've never seen adenoviral stromal keratitis so far. So probably immune, and it's new to me as well. I haven't seen it.
I have a question. How did you send the PCR? Was it a conjunctival swab that you sent in the transport media?
Yeah, it was a routine microbiology, like as we deal with any corneal scraping. I mean, in smear and in PCR. And also,
usually, when we are sending a PCR for adenovirus, we are using the swab, just like the COVID swab, and you can take it twice or thrice from the medial to the lateral side in the conjunctival fornix, without touching anywhere. And then you put it in the viral transport media, and that we transport it to the virology department where they do the PCR.
so we got it from the corneal scraping. So we didn't take a conjunctival swab. We got it from the scraping itself, from the cornea.
Because I'd just like to make clear, because none of the picture, like 5 pictures you showed, most of the cases, whatever we have seen of microsporidiosis, though there are multiple forms of presentation, but most of the presentations are multiple small stuck-on lesions. But in your case, it was sort of a multifocal stromal infiltration. None of the cases like 80 to 90% or maybe almost 100% cases which we saw and reported in BGO, they were all multiple small stuck-on lesions. But in your series, whatever picture you showed, all of them had a sort of ring infiltrate, and many of them have multifocal blotchy areas of infiltration, which is classical of one of the presentation of microsporidiosis. Yeah.
So like previously.
So is there any correlation with such presentation of microsporidiosis with adenoviral?
So
And did you see any classical adenoviral conjunctivitis also in these cases, or these was purely a corneal involvement of adenovirus?
So when we retrospectively thought about it, most of the cases which we see like this previously were treated as HSV. But only significant difference which we can find from HSV is none of them had any KPs or AC reaction or any significant vascularization. That is the difference which we can make out from HSV. So like we decided to scrape, then only we got incidentally adenovirus and microsporidia, and then we stopped using acyclovir in any form in this patient. And they didn't recur. We have a follow-up of 18 months of 15 out of this 20 case series. And prospectively, we have followed cases of microsporidia for 6 months, which were treated in our institute. And out of them, we saw that this kind of presentation was also seen, like as we prospectively saw this microsporidia cases. having a sequelae like this.
Did you
Amrita, so
serotype?
how was
Did you perform serotyping of this virus? Did you have the serotype like it was adenoviral 8 or 4? That is what we see most commonly.
Yeah.
I don't know what was the.
Yeah, we have done that. It is 8 for adenovirus and it is Vitaformi for the microsporidia. And just to see that, because it was done in our Bhubaneswar Institute where microsporidia conjunctivitis is somehow endemic. It is very common there because it's a coastal area. Just to rule out that whether it can be seen in normal patients, I mean the PCR, we have done in PRK patients of 50 patients where we have done PCR for microsporidia just to see that whether this incidental finding of microsporidia is just a pure coincidence or whether it is associated with the pathology. None of the 15 PRK healthy patients' cornea scrapings revealed microsporidia DNA.
Did you do for adenoviral as well in these patients?
Yes,
the normal
yes.
patients?
Yes, we did.
And all were negative?
Yes. In 15 cases we have done, just because we didn't get any positive value. So we just stopped there with 15.
It was quite interesting. So I think we can move on to the next case. So we have the fifth presenter. She's Dr. Hitisha. She's a junior resident at the Advanced Eye Center, PGI. And she'll be talking about bilateral punctate keratitis, a masquerade.
Good evening, everyone. I'll be discussing a case of bilateral punctate keratitis presenting as a masquerade. A 28-year-old female presented with complaints of both eye blurring, grittiness, and watering for 10 days with history of LASIK 7 years back. On examination, she had bilateral punctate epithelial erosions with subepithelial opacification seen on slit examination. On ASOCT, there were focal raised epithelial lesions with subepithelial opacification and back shadowing in the corneal stroma. The scrapings were sterile for routine bacterial and fungal cultures. So now there was a dilemma whether this is adenoviral keratoconjunctivitis with subepithelial infiltrates or is it microsporidial keratoconjunctivitis. Now treatment for subepithelial infiltrates is topical steroids, but steroids can cause progression of infective keratitis like HSV, microsporidial, bacterial and fungal. So we erred on the side of caution and started the patient on topical antiviral and voriconazole for the microsporidial differential diagnosis. 2 weeks later, we can see that there was worsening of the lesions and they were localized to the anterior stroma now. So at this point, we revisited our history and we found that the patient had on and off symptoms of similar complaints for the last 15 years, which resolved to the usage of topical steroids. So now we have a chronic disease with waxing and waning course, which started in second decade of life and responded to topical steroids in the past. We went ahead with confocal microscopy, where we can see there is a typical starburst appearance in the superficial and deep epithelial layers, and there is activated keratocytes and Langerhans cell invasion of the anterior stroma. Now, based on these findings, we made a diagnosis of Thygesen superficial punctate keratitis, and we started the patient on topical steroids. 2 weeks later, there was complete resolution of the lesions. She had recurrence of the similar lesion on attempt of tapering of steroids, so we maintained her on alternate day fluoromethalone and has been asymptomatic for 1 year. Now, Thygesen superficial punctate keratitis is a close mimic for adenoviral keratoconjunctivitis because even though the disease is localized to the epithelium, a prolonged disease can cause subepithelial opacification and can confuse with stage 3 adenoviral keratoconjunctivitis. So what may help? A detailed history of recurrences, clinical suspicion, and ASOCT and confocal may help in reaching the diagnosis. Thank you.
I think this is a very interesting case and not a very common entity. So I would like to have comments from Dr. Merle.
Yeah, I think she's actually covered everything in the slides where the lesions actually are involving the epithelium and may involve the subepithelium as well. The interesting thing is that it's a waxing and waning disease, heals without any form of scarring, and responds very sensitively to steroids. It's a very acute response to topical steroids. They get immediate relief, and then I think what's been shown in literature is that, and our experience also is that the immunomodulators definitely help in preventing future recurrences, but they have to be on it long term. So it's important to differentiate from adenoviral conjunctivitis. Obviously, there would be that prior history of congestion, I mean the redness, and this subepithelial infiltrates would occur 7 to 10 days later. So that history would be there, while Thygesson's patients actually would not have a history of congestion and the typical symptoms that you find in a patient of adenoviral conjunctivitis. The other differential obviously would be microsporial keratoconjunctivitis, which also has a history of redness, but doesn't have the recurrences and has coarse SPKs confined to epithelium, which have got the stuck-on appearance. So clinically, it's a diagnosis which you have to make by ruling out everything else, but then you have this classic history that you need to elicit of the waxing and waning, and the lesions are actually evanescent. If you find SPKs at one visit, at the subsequent visits when it recurs, it doesn't recur in the same place. So that's another feature that one needs to keep in mind.
Yeah, thank you, ma'am. I think it remarkably responds to steroids, and that is a clinch in the diagnosis. So, Dr. Amit, do you have anything to say for this Thygesson's SPKs?
To unmute yourself, Dr. Amit.
Yeah. So this patient came with this kind of irritation in the eye. The main aim, I think, here is that we have to keep an open mind and not just jump into a diagnosis of subepithelial infiltrates or microsporidia. And at what point to investigate these patients. And I think the confocal microscopy, as she showed, revealed that kind of starry sky kind of appearance of those bright highly refracted bodies at the superficial level, and all of these it helped us to just control the symptoms in this patient. And how often do we see the Thygesson's? I think it's grossly underdiagnosed, but I would like to know from the panel, how often do you make the diagnosis here? Because we've made it fairly rarely. I mean, I don't think it's very common for us to make this diagnosis. Is the scenario any different in South India? Do you see more patients with that? I don't know.
I've seen 3 in my practice. So I don't know if that gives you a number, but 3 in 30 years, 2 while I was in practice.
I've seen quite a number of cases of Thygesson's and some of them keep coming over years to you. Maybe again in referral practice, they're misdiagnosed elsewhere, or but I've seen quite a number, at least once in every 6 months or a year, at least. I'm sure that much I must be seeing.
I would agree with Nikhil. In Western part, we do see not so often as Dr. Nikhil is saying, but yes, even I have seen quite a good number in these many years.
Well, I guess one possibility can be that when you are in a place where you are possibly one of the not as many cornea specialists available. So these cases which are so recurrent may end up in your hands at one point of time. So that's one possibility where probably it may not tell us the actual prevalence what's there. But yeah, in your practice, what that speaks that anything in the West, it's going to end up in one of your hands.
So can I make a comment? So whatever 6-7 cases I have seen in my last 40 years career, the clinching is, as we have said, most of the time it's recurrent. And I have yet to see these leaving a scar in the cornea. I have yet to see. I don't know the experience of others, but most of them, like adenoviral or microsporidiosis and other things, they usually can leave a scar. But I have not seen in all those patients varying from 10 years to 35 or 40 years of age, recurrent episode, but no iota of any scarring. All of them becomes absolutely clear after the episode is over. Any experience of other people regarding the scarring or opacities in angiostoma?
True, agreed. It does not leave scar. Also, as everybody said, response to steroid, response to very mild form of steroid also. I mean, it's such a hyper-responsive lesions that very low dose response went very fast.
Only yesterday I had one more case. Only today somebody showed me. So the history of recurrence and usually bilateral things.
I think in all these cases, according to me, the most important diagnostic device, or rather I would say documentation, would be a slit lamp photo. it's nearly impossible to document by drawing it or by remembering it or by possible whichever way descriptive documentation. You really can't understand whether the lesions are coming in same place, whether it's microsporidia, whether it's adenoviral, whatever it may be. I think a slit lamp photo would be a very, very important documentation which can be compared in future to know about where exactly what's happening to these lesions.
I just remember one child who used to come almost every year for 3-4 years. So we try to analyze, scraped off those superficial epithelial lesions. We did microsporidiosis, adenoviral, herpes. Nothing came positive. So because he was coming regularly, so we labeled him as Tyson. So, and every time we give mild steroids, Lotipred also clears it up.
So other thing which I would like to suggest, in most of the cases, rather all the cases, I saw that we possibly didn't select for the presentation, but I think fluorescent stain has to be extremely important part of all these documentation. I strongly feel that we should keep a photograph of fluorescent stain in these things. Whenever you were showing slit lamp photos, whether it was conjunctival ulceration or something, I strongly feel that it should be followed up with a fluorescent stain photo, and preferably yellow filter one. I think it tells you a totally different story.
Yeah, totally agree with you, Dr. Himanshu.
Dr. Itisha, a question for you. Do you think there's any genetic predisposition for the Tyson's keratitis?
Sir, studies have found association with HLA-DR3 positivity in these patients, but there are no long-term studies that have proven that it is a definite association, but it has been associated with HLA-DR3 in quite some cases. And sir, I wanted to add one more thing. The original patients that were diagnosed with TSPK by Dr. Thygesen, their group have followed up a bunch of these patients for nearly 30 to 40 years. And they have documented anterior stromal scarring in these patients because of the chronicity of this disease. More the number of recurrences they have, more is the chance of scarring in these patients. So there is a paper by Dr. Thygesen and his group who have documented scarring. They have a follow-up of 41 years for one of these patients, and that patient had anterior stromal scarring. So
only one patient, or?
The 41 year was one patient, sir, but they had, I think, 5 to 6 patients who had scarring over 20 to 30 years of follow-up.
There's such a gray zone between all these viral and this thing. So definitive diagnosis of many of these things can be sometimes quite tough. And in best of the best hands also, we may falter there. So during that time, possibly even our knowledge of rest of the viral keratitis was not as great. So with due respect to the author, they might have included some of those other cases also, which is possible.
Right.
Yeah, I would like Dr. Paras to share the results of the survey. I think the final 2-3 questions left.
We all know that, this is a very contagious disease, and few of the countries have even decided to have, this to be a reported condition. So based on that, we looked at even the other, questions like whether for hand disinfection, 70% isopropyl alcohol alone is sufficient or not. And approximately 30% people mentioned that it is a false, while 70% agreed that it is true. Anybody would like to comment upon that? We have varieties of, disinfectants available in the market, and we have been, trained to clean the surfaces with probably, absolute alcohol, and when we were trained for looking after these cases. So anybody would like to comment upon this? There are many reports on this, and Anchal, would you like to comment on this?
Yes, ma'am. I would like to cover this in my next presentation also.
Okay, so you would like to keep it, I mean, as this. Okay, then do we have one more slide?
I think the last slide.
One more question. Okay, there are many questions. Many a times, the practitioners, they ask us that how long we should, I mean, even the patients would ask us whether we should send our child to the school, or we should, I mean, attend the office, and whether how long we should, I mean, keep ourselves, isolated kind of thing, so that we don't transmit this condition to any other people. So based on that, we had designed this questionnaire. How long will you advise us or not to go for work when you diagnose a patient with adenoviral conjunctivitis? Many a times the surgeons, when they have this conjunctivitis, they do ask that, when can I start my surgeries? So based on this, I mean, people responded, we had, different responses here. Some people say that they would like to, I mean, keep the people, I mean, advise rest for 3 days, 5 days, 1 week, or no rest is needed. So do we have any consensus on this? I would totally agree that, depending on different strains of adenovirus, the infectious or, the contagious phase would last for maybe probably 2 to 3 weeks. So any comments from Dr. Rao about this?
There's no scientific basis, but basically I tell them 3 to 5 days.
3 to 5 days?
I mean, telling them, yes.
I think it depends on which side we are. If you have the disease, you might want to believe that 3 to 5 days and you are good to go. If your colleague has the disease, I wish that's much longer than that. We all know that it's very difficult to have quantification of the virus and the contagion. I'm sure Anchal is going to take up, but whatever we like to believe, isopropyl alcohol does not actually kill most of them. The contact time required is much longer, 10 minutes for strain 2 and 7, and even strain 8 is not even susceptible to. So we may believe that we just clean our hand, and washing hand, interestingly, is not a common practice in schools. So I'm not sure that how good we are at others. I mean, thinking about others, but I think it boils down to the practicability, that can we give such long leaves to people?
Yeah, I just want to comment here. Actually, in sanitizers in general practice, we have just 2 types of sanitizers. We have one containing ethyl alcohol and one containing isopropyl alcohol. So this adenovirus is like a non-enveloped resistant virus, which is not very sensitive to isopropyl alcohol because it doesn't have that envelope. So using 70% ethyl alcohol is more effective against adenovirus. So isopropyl alcohol is, you are right, is not effective. So we should use hand scrubs and sanitizers containing ethyl alcohol or ethanol. And I think it is available in the hospital supply, which we have in PGI. And most of the sanitizers have that. So we need
Anchal, the other important part is the contact time. So
that's very important.
What is the contact time required for ethyl alcohol?
Yes, they say 3 ml, 2 pushes, and that's for 30 seconds.
So does it kill all the virus in 30 seconds?
Actually, CDC guidelines, they say that this is sufficient to kill, but there are many studies about the contact time. So this is the guideline which I got after going through all the studies. And for surface disinfection, it is again hypochlorite and not alcohol, because it is corrosive and you cannot clean all the surfaces with.
I think we all went through all such kind of thing during COVID, and spoil our furnitures, instruments, and everything else with whatever possible corrosive things, and realize that nothing is going to help us other than washing our hands. I think hand wash would be at least a decent practice for that.
Yeah, can I comment? The combination of an isopropyl alcohol with the quaternary ammonium compounds, that's actually the best, because it brings down the concentration of isopropyl alcohol. And regarding the leaves, the recommendations, one of the recommendations that I came across was a 12-day off period after having started the first symptom of adenoviral conjunctivitis. And it's very difficult to give that kind of leave. We are not giving that kind of leave to our residents in PGI also. And one study that we did conduct was on the role of ganciclovir in adenoviral conjunctivitis. So what we did was we did take repeated swabs, and we actually quantified the viral load in that. And these patients got topical ganciclovir along with it up to day 10. And we compared it with the control group, which was just carbomer gel in these patients. So we did get a significantly high viral titer even on day 14. So although the patients were symptomatically completely healed, and again, when it comes to treating these patients, just a comment I wanted to make was that adenovirus has different manifestations, one of them being the pharyngoconjunctival fever, and the second important one being the epidemic keratoconjunctivitis. Now, classically, if we get a patient who's coming, history of diarrhea, rhinitis, fever, it would probably, I would put it in the pharyngoconjunctival fever, sore throat, things like that, where classically the incidence of subepithelial infiltrates is not that high. Responds wonderfully well, may heal by itself. On the other hand, the epidemic keratoconjunctivitis would have a much more severe involvement, epithelial defects, filamentary keratitis, pseudomembranes, and classically severe unilateral disease going on, spilling over to a bilateral thing, where we would be more aggressive. My algorithm for treating these patients, such kind of patients, depends on when they present to me. If they're presenting within the first 3 or 4 days, the famous saying that we keep sharing amongst each other is an ounce of prevention is worth a pound of cure. So the thing is that when we look at ganciclovir, the mechanism of ganciclovir is that it enters the cell and can kill an intracellular virus. Whereas when we look at povidone iodine, it acts on the surface. It is virucidal. It can prevent the replication. It can prevent the attachment of the virus to the corneal cells. But it does not kill the intracellular virus. We do have patients where we have tried both as well. We are trying to analyze that as well in these patients. Because these drugs cause aggravation of inflammation, there may be a role of giving early steroids, as long as you're covering them with a virucidal thing. Our study on ganciclovir did not reveal any significant difference in the efficacy of ganciclovir versus the placebo, which was the carbomer gel. But definitely the severity of signs and symptoms, and also the intensity of the subepithelial infiltrates was much lower in the ganciclovir group. Nothing significant to report. Just a comment. Thank you.
Do we have any more, cases, Anshul? I think we are done with 5 cases, right?
Yes, ma'am.
And before we conclude, I would like Professor Jain to probably sum up the management part of adenoviral keratoconjunctivitis.
Ma'am, can I present first and then we can have the conclusion?
Oh yeah, we can do that. Yeah, sure.
Yeah, so are my slides visible now?
Not yet.
Not yet.
Until you have to share screen.
Yeah. Is it visible now?
Yes.
Yeah. So I would like to present my clinical presentation, investigation, and control of an outbreak of adenoviral conjunctivitis. This happened around 2019, and we had 94 suspected children, like neonates, who underwent adenoviral conventional PCR sampling. And we had 58 confirmed lab patients. Okay. So we had to review all the medical records of the neonates, staff interviews and observations were made. We tracked the source of this outbreak. So environmental samples were collected from the bedside of patients, trolleys, tables, and door handles. It was found that same ocular drops was used when the ROP screening was carried out in the ward as well as in the clinics. So samples were taken from the drops also. And again, samples were collected from the 20D lenses and indirect ophthalmoscopes in both the outpatient department as well as in the nursery. So it was interesting to note the various signs and symptoms in these 58 proven adenoviral neonates. We found around 77.5%, that is 45 neonates had pseudomembranes, which was quite alarming. And this is like a clinical picture. We have a subtle discharge along with mild congestion and very subtle pseudomembrane. And these were seen as early as day 3 of adenoviral conjunctivitis as compared to adults, in which we see later. Also, some children or some neonates had just mild conjunctival discharge without any congestion. So we are often confused that is it bacterial? Should we give only antibiotic? But they had proven adenoviral PCR. So these are some of the pictures in which I found varied pseudomembranes. Some had very subtle mild congestion with a minimal pseudomembrane, and some had a very thick pseudomembrane. But these all were found very early in the course of the disease, maybe as early as day 3 to day 2 also in some babies. So we used to remove all the pseudomembranes and send them for PCR. So why did this outbreak prolong? Because neonates have very subtle signs as compared to adults. And there is also long duration of viral shedding. In some neonates, we did the PCR and again, and we found that as long as 43 days was noted in our study. Also, there are some low birth weight neonates which cannot be discharged, and thus this prolongs the exposure to other subjects. Also, in a busy tertiary in the tertiary institute, we have sharing of the same room by mothers of the infected babies. So it is very difficult to isolate each and every infected person. So these were the control measures which were taken during the neonatal adenoviral conjunctivitis outbreak. Apart from again and again insisting on hand washing and hand hygiene, we had also given povidone 1% to few of the babies after their thyroid levels, because it was not proven that could we start povidone iodine along with mild steroids early in a very small child. So we had meetings again and again with the pediatricians as well as the ethical committee, and we did some thyroid levels before and after giving povidone iodine. Also, we found here a very characteristic link of ROP examination with the adenovirus, and the median time between ROP screening and the onset of symptoms was 5 days. Again, emphasizing that ROP examination led to the infectious spread of the epidemic outbreak. And also we did some serotyping. So we found serotype 8 only in almost all of the patients. We did about 50% of the patients we did serotyping, and we found serotype 8. So as I just told this about the managing the neonatal adenoviral infection with povidone iodine, we could start povidone 1% in 15 odd neonates along with 0.5% loteprednol. And we did find a lesser severe conjunctivitis in patients in whom we gave povidone iodine. The edema was less and the pseudomembrane formation was also less in patients with povidone iodine and loteprednol. So I'll not take much time because this is a very big topic. Literature does support the role of povidone iodine in adults. And when I went to search for some neonatal conjunctivitis, I just found that for prophylaxis of ophthalmia neonatorum, povidone iodine is safe, although a lesser concentration, but the single instillation was quite safe in neonates. And there was actually no evidence of derangement of thyroid function with the use of povidone iodine. So after the ethical clearance, we started giving povidone iodine to the patients who had for this outbreak. So my take-home message would be that neonates with eye discharge should be followed up very carefully, as it can be because of adenoviral infection. A subtle discharge can have adenoviral infection, and neonates especially, they can have complications like development of pseudomembranes linked to prolongation of the disease. And obviously, standard operating procedures for ROP screening should be in place and followed rigorously in all NICUs and ROP clinics to minimize the infection. Disinfectants with virucidal potential, which we emphasize, like 70% ethyl alcohol, should be used for cleaning and washing, sanitizing our hands. Thank you.
It was a nice study, Anchal. And any comments on this? Any other institutes are following a similar kind of a protocol for any outbreaks?
I just wanted to ask you, since you are working in an institute, is there any prophylaxis which is followed normally in pediatric, like when the baby is born, is there any prophylactic protocol in place for eye, or is just only SOS if they get a red eye or something?
Sir, I don't think so. There is a protocol for all the babies being born at the tertiary institute, and if there is red eye, then we usually intervene.
Okay.
So I was going to add that we routinely track new cases of adenoviral conjunctivitis as part of the NABH surveillances that we do, and if there is any evidence of a sudden increase in the number of patients developing adenoviral conjunctivitis, if there's a cluster, then that is investigated. But we've fortunately not had, this kind of an outbreak that has come to our notice.
Very nice presentation.
The challenge here is that, having a bit of yellowish discharge is not uncommon in children, especially premature, because the nasolacrimal passages are not developed so well. In so many babies, we find that. So I think for some time, they didn't even realize what is going on. And it's only later on that with these patients with pseudomembranes and all started coming in. Our department has a very, very close relationship with the pediatric people, because we have a very, very strong ROP practice at the Advanced Eye Center, PGI Chandigarh. So I think that is how, but there's no doubt that ROP screening contributed in a very, very big way to spreading it. So probably some patients who came to the ophthalmology OPD, and then a resident got a call, and they picked up their lenses and indirects and walked off to the pediatric ICU to see these premature babies. And then one child got it, then something, it was on the surfaces, the beds, because that area is just full of these kids and mothers on the beds. There's a feeding area. I think Anchal can tell better because she documented so much of it.
Anchal, how did you manage those membranes? Did you remove them or no?
Yes, I used to go and we used to remove the membranes. And if we remove the membranes, I think the penetration of the drug is better and there is less inflammation once we remove it. So,
in fact, this happens with those people who are immunocompromised, and typically when the neonates are behaving like that. Those who are on any organ transplant or BMTs and they get adenoviral, they do get a very similar picture of not so bad inflammation, but having the membranes and these things. And unfortunately, those bachus fell into that category. Hence, does not show the picture like an adult. So the same virus, the same load would behave a little differently in adult versus. So Mal was asking how were the mothers, possibly their presentation would be a little different from these bachus when they.
Definitely, sir. The mothers had the typical adult presentation, but none of the babies had lid edema, which we characteristically see in almost all patients. So there was no lid edema, mild congestion, and very, very, very common for the pseudomembranes.
You said you sent pseudomembrane for PCR, so it's like a dead exudate, but did it have the virus? Or
Yes, sir. Because we had so many pseudomembranes, so we were trying to find out that is it also like having active virus. So PCR was positive for many pseudomembranes also, but we are not sure that
when there is still active disease process, the PCR being such sensitive, it ought to come positive. Yeah, I mean, so very interesting.
We have some questions in the question answer chat box. Dr. Adhika Natarajan has commented that EBV is a rare cause of bilateral SPKs in patients with Western travel, and we agree that we have to differentiate these cases from other causes of bilateral SPKs. There is somebody anonymous who is asking role of lubricants in such types of conjunctivitis. Obviously, it goes without saying that these patients would be more comfortable with lubricants in addition to topical antibiotics. There is a question from Sapna Kiri. Some SPKs stain like microdendrites in cases of supposedly adenoviral conjunctivitis. Any change of treatment in such cases? Dr. Mal, would you like to answer that question?
Sorry, just repeat the question.
Some SPKs stain like microdendrites in cases of supposedly adenoviral conjunctivitis. Any change in treatment in such cases? Would you like to change your treatment plan for such cases? If they look like microdendrites.
I actually haven't noticed that, because the SPKs that we get with adenoviral are typically these small little dots clustered together. I don't know if others have noticed this kind of microdendrite appearance. I haven't. Maybe the others can answer.
No, even we have not noticed any of these microerosions developing dendrite-like pictures, especially in any of the cases of adenovirus. But of course, if there is a macroerosion, once the epithelial defect heals, they can form pseudodendrites, and you don't need to change any treatment in such cases.
I think we answered that question in the earlier part.
Yeah.
With the toxicity to the, corneal surface.
Right.
See, all these viruses, whichever are epitheliotropic virus, will make the epithelium sick. And sick epithelium has a fate that it's going to undergo apoptosis. So when there are multiple cells which are close to each other and undergoes certain apoptosis, you may have a thing which may look like dendrite or something. But I think clinically we know that looking at that, would we be diagnosing them as an HSV? Possibly not. So I don't think it's going to change anything much out there.
How many of us use gloves for examining these patients? I saw she was using gloves in a baby. And I was just reading this article where it said, use gloves. But frankly, we figure out that eye is red and patient walks into the clinic. I have not been using gloves. I wash my hands and I use a sanitizer or whatever after that as well, and clean slit lamp and all that. But I thought it's a good idea now with COVID that we can use and throw it away, so that possibly less washing and less surface, at least on our hands. Anyone uses it routinely?
Strictly use gloves. In fact, we also put those tissue paper in the forehead part, chin part, so that we can contaminate the slit lamp as less as possible, preferably taken only in one room, and preferably only one person sees and not multiple in the hierarchy. These patients are like the triage in a way that they don't undergo unnecessarily testing or anything, just to reduce the contamination.
What I use is I keep these cotton buds. And so because these patients in acute stage don't really require a very, very thorough examination. So you can just pull the lids up and put the lids down and then discard that bud, possibly in hypochlorite, but you can discard it. So there's no touch from your hands.
Yeah, the Q-tips are very handy in all viral infections.
Yes.
Especially even zoster patients when you are examining those patients as well.
Correct.
But if you use only Q-tips, then many a time you can miss pseudomembrane forming underneath.
Absolutely.
So you can't evert the lid with a bud. With a single hand, at least. You have to use two hands.
Agree.
I was reading somewhere a recommendation that many people use sprays, those sanitizing sprays to, on the slit lamps and surfaces. They say it's not a good idea because you might leave portions with the viruses intact. So you should use a wipe and you should wipe the surface. That's the correct way to do it.
So,
If we are done with the questions. Can we have concluding remarks from Professor Jain?
So I think we have discussed all aspects of this adenoviral keratoconjunctivitis, and all of us sees these patients in different stages of evolution: acute, subacute, chronic stage. And as well said by most of us, that we have to differentiate it from the different masquerade, which could be herpes simplex, herpes zoster, or even Tajidin keratitis, or what we call toxic keratoconjunctivitis or medicamentosa. So one has to keep in mind the differential diagnosis, but the diagnosis is usually classical, and most of the time clinical picture clinches the diagnosis. And if you are not sure, one can do a rapid adenovirus test, which will again confirm the diagnosis. And as shown by the surveys also, and all the panelists also agree, in acute stage, we have to give tear substitute, some topical antibiotic to prevent superadded infection. And all of us don't agree as far as using steroid in the acute stage. And indication for steroids are already, as been said by, elaborately said by Dr. Rao, that in case there is a severity of the disease is too much, there is a browny edema of the lid, pseudomembranes, and all those, we should add on early, after at least 2-3 days, the topical steroid, initially maybe DEXA or FML, but as the disease become less severe, one can switch to softer steroids like loteprednol or fluoromethalone. And the use of povidone iodine has been recent, and it has been shown in studies. It has been not taken as a routine treatment. Many of, but at PGI, we are using it as a routine. And in severe cases, we add on the steroid also. And as far as the treatment of subepithelial, recurrent subepithelial precipitate is concerned, we know we have to use steroids along with the steroid sparing agents like cyclosporin or tacrolimus as and when desired. And in very severe cases, it can lead to a severe irregular astigmatism of scarring. So it's always better to prevent the occurrence of the disease rather than cure it. So all of us have discussed in last few 15 minutes how to prevent the disease, for which we have to meticulously, I mean, everybody should wash their hands frequently and use ethyl alcohol based disinfectants to clean the surfaces, because this is a very fastidious virus, and it remains on the wet surface for almost 30 to 40 days. So keep the surfaces dry. That will also kill the virus, and especially if there is an epidemic, or if the adenovirus is lurking in your clinic or hospital, the tips, the applanation tonometer tips also should be sterilized with this hypochlorite or the bleaching solution. In between, you can have multiple these applanation tonometers and use it separate for separate patients. So at each stage of the disease, the treatment varies, and I will conclude to say prevention is always better than cure. But if still you see the patient, we have to treat as we have all discussed. And with this, I think we can conclude the very interesting and very great discussion about this topic, and all of us see this day in and day out. Thank you so much.
Thank you, sir, for the concluding remarks. And do we have any comments from anybody else? If not, maybe we can wrap up the session. We have had a wonderful session over, adenoviral keratoconjunctivitis. We still are having, many questions, and we need a lot of evidence-based studies to add in some more, management options. but we had a good insight from various cases which were presented all throughout, and even the differentials of SPKs, including even the masqueraders. So we have to keep in mind all these possibilities. I would also like to thank all the panelists, would like to thank all the presenters for bringing in wonderful cases, especially Dr. Anchal for, doing a lot of background work, and PGI team for making this successful event for the first, first meeting of the CSI for the year 2023. I would like to thank the CSI executive members for participating into the discussions, and also would like to thank the back office of CSI, Shabina and group, for making it seamless for the session. Thank you very much. And
from the PGI side, thank you, Paris, so much. And we really enjoyed this. Thank you for reaching out to us, CSI, and we appreciate this. And we really enjoyed this session. Thank you.
Thank you, ma'am.
Thank you so much.
Thank you,
everyone.
Thank you, and thank you, and good night, everyone.
Thank you.
Thank you. Good night. Good night.
Done. Thank you, doctor.
Thank you.